Welcome to the ASC, where we help you survive and thrive in ACL rehab. Today I'm going to take you through phase 2 of your ACL rehab. The goals for phase 2 are to get in the gym, start to progressively load, utilizing pull and blood flow restriction, and avoid any painful ranges of motion like knee over toe, and then increase gym load with sets, reps, and then even days in the gym. Check out phase 1, as you need to pass phase 1 before you enter phase 2. This video series is taking premiership rugby player Charlie Holland from surgery right through to her return to premiership rugby. This video will take you through phase 2 of her ACL rehabilitation. The goals of phase 2 are reintroduction to the gym, preventing muscle atrophy, and improving your body's coordination and control. After watching this video, you'll know when you can start phase 2, what to do in phase 2, and how to progress from phase 2. The purpose of this video and series is to give you an upfront view of a professional standard ACL rehab so that you can pick up tips and tricks to help you on your own ACL journey and to help you avoid common mistakes and pitfalls. My name is Alex Holland, I'm a pro rugby physiotherapist, and I'm programming Charlie through her rehab. And if you have questions, comment them below. In ACL rehab, we've got what we call biological healing timeframes and performance timeframes. Some things just take time to heal, and those are biological timeframes. For example, you may not be able to walk for the first 6 weeks after surgery because your meniscus is healing after being repaired. This is a biological time frame. On the other hand, you've got time frames based on what you can do. These are known as performance time frames. So if you can't get your knee straight or you can't leg press enough weight, this is a performance time frame. And you can't progress through the phases until you achieve these things. It doesn't matter how much time has passed for these performance time frames. To make it easier, I've created phases where I've put both the biological and performance time frames together. In each phase, there's criteria you need to pass. You can't progress to the next phase until you've passed the criteria. So if you're not sure where you're at, check out our phase 1 video and then work your way forward. So when can you start phase 2? It depends what type of surgery you've had. If you had a pure ACL injury that was repaired, you would probably move through the rehab faster than if you've had other injuries at the same time, such as a meniscus repair. Because if you've had a meniscus repair, it's likely that you're not even weight bearing for the first 4 to 6 weeks. Whereas if you've had a pure ACL reconstruction, you may be able to progress into phase 2 earlier, as you're able to partially weight bear pretty much from week 1. Okay, so let's talk daily monitoring, which gives us a sense of how athletes are tracking on the day-to-day basis. Because Charlie's in a professional sports environment, this monitoring is carried out by a physio. However, many of these checks can be done on your own. Charlie needs to display the following criteria to progress her rehab. So first up, pain. Criteria we need to pass is averaging less than a 3 out of 10 pain across a 24-hour picture. I will often ask my patients, how would you rate the pain in your knee if 0 out of 10 is no pain and 10 out of 10 pain is the worst pain imaginable? Is it less than a 3 out of 10? I'd probably consider that to be a pass for this criteria. So we've got the sweep test, which is a physio test that patients can learn to do on their own. It looks at how much swelling is in the knee joint. The sweep test is used to push swelling around the knee joint if possible. We sweep up the inside of the knee just below the kneecap, and then we push down on the outside of the knee. Here is a grade 3 because as I sweep up and push down, there's no movement of the fluid. A grade 2 would mean I can move the fluid, but it refills on its own. A grade 1 is the fluid moves back with the downstroke. This often looks like a little bubble popping back and forth, and in grade 0s there's no swelling. Up next, we've got active knee range of motion. The athlete should have full knee extension by at least 2 weeks post-op. I always aim for at the end of week 1. So this isn't 5 degrees off, 10 degrees off, it's full, absolute full knee extension. And there's no wiggle room with this. So if you take anything from this video series, please make sure that the knee gets straight. Up next, knee flexion. We want to actively be able to flex our knee at 120 degrees. This will get us into phase 2 and allows us to get on a bike. We always want to restore as much range as possible. Lastly, for range of motion, we have tibial rotation. We want to see 5 to 10 degrees of tibial rotation. This is when the actual shin is moving, not just the foot. We need to see the rotation of the shin 5 degrees in and 10 degrees out. So let's talk strength. To be confident that we can return to walking and activities of daily living, such as stairs, it's important that Charlie didn't have a quad lag when performing a straight leg raise. A quad lag indicates that there's muscular inhibition of the quadriceps, in particular the VMO muscle. The main culprit is that there's swelling in the joint, which then causes the muscles to switch off. Practically, if you can't handle a straight leg raise, you'll then struggle with more strenuous activities like stairs or squatting in the gym. So weekly and monthly markers that we look at. So alongside our daily monitoring, we also have weekly and monthly testing that we'll do progressively. We've got movement control and gym strength metrics. Charlie had to pass these metrics to get into phase 2. So, movement control. This just looks at what the athlete can do. If I'm going to program gym exercises, I just need to know the person can do them. And so this is why we'll test them. Athletes need to be able to perform 5 bodyweight squats to 90 degrees without any shifting of their body weight to the unaffected side. If the athlete is shifting, this is an indication that the athlete is trying to protect the surgical leg. We also want to see the athlete can do a double leg hinge or an RDL for 5 good reps and not shifting their weight to the unaffected leg. If they are shifting, it means they're trying to protect the surgical leg. We also want to see the athlete can do banded side leg raising clams, because we want to see that the athlete can perform these without any pain in the knee. There shouldn't be issues doing these movements, but later on the phases, we'll be actually doing strength testing for these movements. So we're just introducing them now. Same as for ankle inversion and eversion strength exercises, we want to see that the athlete can do them and it doesn't cause the knee any pain, and we'll be performing strength metrics on these later on in the series. And the final movement test is the ability to perform 20 seconds of toe taps. This is a great precursor exercise for running. So if your heel doesn't collapse when performing the exercise, this means that your calf is strong enough to tolerate these running forces that you'll experience, and it'll protect the knee joint. Okay, so strength markers. Charlie performed a 5 rep max leg press on her single leg. I wanted her to achieve a 5 rep max of 75% of her body weight to just above about a 90 degrees depth. We're looking for good control of the movement, both at like the top and the bottom of the movement. This was done whilst maintaining a vertical shin, meaning she just wasn't getting too much knee over toe. The reason we test leg press on a 5 rep max is being able to achieve this 75% of body weight indicates that your knee is sufficiently strong to return to other gym-based exercises. For Charlie, who was about 73 kilos, she needed to hit a minimum of 55 kilos. I also like my athletes to be able to perform 10 bodyweight calf raises. This is done from the floor all the way to the top of the ankle at a 60 beats per minute on the metronome. So good reps, full extension of the ankle, and not rolling your ankle out to the side when performing the movement. So guys, congratulations. If you've been able to perform all of these different movements and strength markers, we can successfully progress into phase 2. So what does phase 2 rehab look like? So Charlie's rehab was primarily Monday to Friday. Every day she had to get through swelling management 3 times. Her at-home prehab in this phase would vary in intensity, but it was done daily. The main aim of the home prehab is to just get the knee straight and get the quad switched on. And we always did this first thing in the morning. She would then have gym-based lower body rehab Monday, Wednesdays, and Fridays, upper body on the Tuesday, Thursday, adapted cardio twice a week, and also aiming to go to the pool 2 to 3 times a week. I appreciate that for some people watching this, they might think that that's a lot, and of course it is. As a professional athlete, Charlie's main goal was to return to professional sport. However, the crux of her rehab was to perform her home rehab and to do her 3 lower body gyms a week. I feel like this should be most people's goals in rehab, to always tick off your mobility, quad activation, and your gym rehabs. So, home rehab. Charlie's rehab did fluctuate throughout the rehab process. We did swap some of these exercises out, but this is just to give you a flavor of what she did do in this rehab. Charlie had access to a bike at home and would often do a occluded bike in the mornings for 10 minutes just to get blood flow in the leg and to get her knee moving. She used her Hytro shorts for this. From here, she then went into her mobility, which is the same as in phase 1. So also please bear in mind that Charlie had a patellar tendon graft, so she was able to stretch her hamstrings normally. There's a couple minor differences in phases 1 and 2 depending on your graft type. If you've had a different graft type and would like me to go into specifics, drop a message in the comments and I'll get back to you ASAP. So back to the rehab. Charlie then went on to do her Compex quad set, where she achieved 1 set of 10 reps at maximal effort. This ensures that her VMO is switched on. She would get to about 150 to 200 on the Compex when doing this. Essentially, this just shoves a bunch of electrical stim into the quad to ensure that it's working maximally. Just a note for everyone at home, a Compex is an EMS device. It is not a TENS device. With the Compex done, Charlie then moved on to her foot and ankle exercises, which were the same as in her phase 1. Charlie then performed some inner range hamstring manuals. This is where she lies on her belly and then tries to hold it in that inner range. We gently try and push against her to make that hamstring work harder. If you don't have a partner to help you, we can just replace this with a standing hamstring lift off. However, this exercise is limited by how much knee flexion you do have. But the important part about this is do not neglect your hamstrings. They are extremely important in stabilizing the tibia and help you control your knee when decelerating. From there, Charlie performed an eccentric clam or side leg raise. This is one of those exercises that we swapped in and out on a daily basis because we didn't do both on the same day. Clam focuses on the external rotators of the hip, whereas the side leg raises focus on the lateral hip. Similar to the hamstring exercise, we take the leg up as high as possible whilst maintaining a solid contraction of the muscle. For all of these exercises, we keep the sets and reps low, so about 3 sets of 5 reps, and each rep we're trying to fight against that resistance for about 5 seconds. From there, we moved on to some single leg balance exercises. Starting off, we're balancing on a single leg with our eyes open. You can then progress this to eyes closed. You then make it more challenging by moving your head up and down, side to side. As your confidence grows, we then add a more unstable surface and then progress through the exercises. The key here is do what you can safely. We don't want you to fall over, but if you can do it easily, we just want to progress you along. Finally, we moved on to some patellar tendon loading. As mentioned before, each graft type has its own little processes that we need to go through and exercises that are important. For a patellar tendon graft, patella tendon loading is important. For Charlie, she did a double leg wall sit for the patella tendon, 3 sets of 30 seconds. So that's the at-home rehab. Let's talk about what Charlie was doing in the gym. This was one of Charlie's 3 gym rehabs from phase 2 early on. The main warm-up she did was a repeat of her knee mobility from the at-home rehab and her Compex again. And we also did a short bike to get the knee moving. From there, we moved on to her run prep. The key word here, it is prep, it is not running. In these early stages, I still like to get people practicing run drills so that when you can run, you are actually ready to do so. In phase 2, I mainly focused on triple extension, which is when we extend through the hip, knee, and ankle. This meant that I wasn't putting Charlie's patella tendon under any stress. And this is just a great way to get players drip feeding proper run technique early so that they're ready to run later down the line. We performed these exercises back to back as a tricep. We started with triple extension iso holds, followed by a banded wall march, and then finishing with a hip lift over a hurdle. From there, Charlie moved to her main block of gym, and this is the strength section of her rehab. We started off with a step down, focusing on control of the hip and leg, and then we went into single leg press. Because of the patella tendon, we made sure Charlie was lying as flat as possible in the leg press, with her foot high up on the plate, which keeps a relatively vertical shin angle. Basically, we didn't watch too much knee over toe to protect her patella tendon graft site. Because Charlie in this early stage still can't press a lot of weight, by adding the occlusion, the exercise is harder. She's able to recruit more muscle and get more out of the exercise. So for this, we use Hytro shorts. They're really easy to get in and out of. They're great for rehab. If you want any more information on this, just chuck it in the comments and we can do another video on that. From leg press, we moved on to single leg hip thrust. This works on single leg hip strength and primarily glutes and adductors. Then we moved on to seated soleus press for the calf. And you can see with the exercise selection, we're still keeping a nice vertical shin angle. And then after the main strength block, we went into another occluded exercise finisher, which was a double leg squat, single leg RDL, and finally a single leg calf raise for 3 to 4 rounds. And finally, we then went on some core. Core is really important because strong trunk strength is important when changing direction. It allows us to be in control of things above and below the knee. So we don't want to have a weak core when returning to sport. So that was Charlie's main gym session for the first part of phase 2. She actually repeated that twice in the week. So that was the Monday and the Friday. This was the other gym session that she was doing in the middle of the week. It follows a similar format, but it's a little bit easier. So have a look at that one. We're then going to move on to the gyms that she was doing at the back end of phase 2, just to give you a flavor of how things progressed in this really important phase. So that's the first half of phase 2. By the end of phase 2, Charlie was actually able to tolerate 4 lower body gym days a week. We made the gym split into an anterior and a posterior gym split. So on Mondays and Thursdays, Charlie would do her squat-based and leg press movements, but she also had some other hamstring top-ups on those days. But Tuesdays and Fridays were primarily posterior only days. With these sessions, we started out with a normal warm-up, including Compex bike and terminal knee extensions. She went into her prone hamstring isometrics to work on those inner ranges of her hamstring strength. We then went to hamstring slide outs, where we started at double leg slide outs and then progressed onto single leg hamstring slide outs. Then went on to safety bar calf isos to load up her calf, which we progressively loaded over time for 4 sets of 10 seconds, adding weight gradually. And then she went into her prepared to run session of the gym. So you can see here, Charlie's doing some variations of those triple extension exercises that we talked about earlier. We avoided doing exercises that focus more on like deceleration and change of direction, because this would be too taxing with her patella graft, because we're already putting that patella tendon graft site on some stress with her basic exercises in the gym. By the end of phase 2, Charlie went from normal leg press to eccentric single leg press, because it's really important to load up the quad tendon slowly over time, because this is how we learn to decelerate and get into those change of direction positions. Eccentric training is essentially just the lowering portion of the exercise. By doing this, we're able to put on more weight than Charlie could actually move up and down. It's just on the lowering part, so the weight can be a bit higher than what she's able to tolerate. These weren't maximal at this point in time, but in the next phase, they'll become super max, where she's able to load up so much heavier than what she's able to push on her own. Gradually, we began to lower her foot position on the leg press, getting a bit more knee over toe. This happened gradually over the course of phase 2 and also into phase 3. So if you had a patella tendon graft, you would need to do this gradually, because it does put the patella tendon graft site under more stress, and we need to just be very gradual with this, that we don't flare up that patella tendon and get patella tendonitis. If you've had a hamstring graft, you do not need to worry about this, but more for when you do your hamstring exercise. And just to be clear, when we're talking about graft site, I'm not talking about your lovely new ACL, I'm talking about where the ACL came from, which is that patella tendon at the front of the knee. Once we did that single leg eccentric leg press, Charlie then moved on to her clam exercise again. And then we actually went on to a low bar back squat. Now you might be wondering, why is she doing low bar back squat after leg press? because this was a patterning exercise. She was just learning to squat again, and the weights went up gradually over the course of phase 2. So for example, Charlie's able to squat heavy when she's not injured. She was able to do a 120 kilo back squat, but at the moment she's just patterning, only 60 kilos on the bar. We sometimes occluded this as well, just to make the exercise a little bit more challenging without putting too much weight on her back and on that knee. The point is, when we actually can get Charlie to squat more and heavier, she's already done it for a period of time beforehand, so she's got the technique down and she's ready to go. So that was the anterior day. Now we're going to talk about Charlie's posterior day. So her usual prep, then we go into a tri-set of exercises, a B stance RDL to load up her glutes and hamstrings, single leg bodyweight calf raises on the slant board. The point of the slant board is it gets her to load up that big toe, and then a foot dome exercise, which works on those foot intrinsic muscles. What that is getting your foot flat and then creating a hollow arch underneath without actually scrunching your toes. And I'll do another video to cover foot intrinsics, why they're important and what there is to know, so be on the lookout for that. From here, we moved on to another main exercise, which is a single leg hip thrust. This is one of my favorite levelers in the gym. It's a brilliant exercise. It loads up the glutes and adductors. And Charlie will kill me for saying this, but she couldn't do a bodyweight single leg hip thrust 4 years ago. She's come a long way. It's such a great exercise for developing that posterior strength. So hip thrust done, we then went on to a superset. We had an adductor plank, also known as a Copenhagen, with a side lying clam. Finally, we went on to that core again, which we had hanging knee raises, hollow holds, and then a side plank. We did this as a tricep finisher at the end of the session. At the back end of the week on a Friday, the only change we had was we added a little bit of extra quad because she was going to have the 2 days off. So she'd do anterior on the Monday, posterior on the Tuesday, repeat that for Thursday, Friday. But just on the Friday, we'd finish with a little bit extra. So often this was a reverse sled drag, or it was leg press again that was occluded, just to make sure she got that extra hypertrophy and stimulus in that quad. So what about Charlie's unaffected leg? So Charlie always did exercises on both legs for these exercises we just went through. However, her non-surgical leg also had a couple exercises a week that it would do on its own. We did this to make sure that she got as strong as possible on her opposite leg, which gave her a really good goal to work towards. So we did knee extensions and hamstring curls on that side twice a week, 2 to 3 sets of 8 to 10 reps. This made sure that she was topping up that leg to be as strong as possible, so that we knew that if we got her surgical leg to the same level of that leg, that she would be in a really strong place. So for me, this is really important to train the unaffected leg, because we always want to make sure that that leg is as strong as possible, especially when we get down to the nitty gritty and testing, which we'll have in another video later down the line when we do our IKD testing. It's really important that we are strong, not just symmetrically side to side, but in reference to our body weight, because there's no point being symmetrically weak. We want to be, if anything, asymmetrically strong. So it's really important that we are as strong as possible in returning to play after ACL. So much of Charlie's success in this early phase is to do with what she did in the pool. By being in the pool, you're de-weighted, you weigh a lot less, you get a lot more free reps, the knee gets to move, you get to feel better, you can feel like an athlete again. I really encourage people to get in the water, get their knee going as soon as you can, but you got to make sure that there's no risk of wound infection, so your scars have to have healed before you get in the pool. However, it is the best place to do your rehab early doors, so I encourage everyone to do it. We've done a whole YouTube video on this, so please check the link in the description and have a look at that video as well. So in phase 2, we can do cardio in some creative ways, but the key is that that affected leg is not doing anything. We don't want to waste any reps or have that knee get swollen because we're doing cardio. So we use no legs assault bike, a single leg rower, or a seated ski erg as our 3 modalities to achieve some cardio for Charlie. The aim was obviously to get a quick and easy cardio stim that didn't go for too long. Here are some of the options that we had for Charlie. We got to pick and choose what we wanted, and it sort of varied week to week just to keep things fresh and interesting. Just please keep in mind that in this section, this was Charlie's reward for a really hard week of rehab, doing things she didn't really want to do. So if you don't feel pressure if you don't want to have to do cardio at the end of your rehab week. Upper body workouts are a great thing in ACL rehab because you can train as if you would normally. Charlie did 2 to 3 upper body workouts a week. I always tried to keep her to 2, but she always tried to sneak in a 3rd. However, I do have restrictions on the amount that she can walk around the gym, so I make sure that she can set up in the same place, that she's safe, and that she's not pushing through her leg much when she's in the gym at this point in time. So guys, thanks for watching. Please keep in mind that our ebook is launching on the 29th of August, and thank you for being part of the ACL Survival Club. Stay tuned for phase 3, where we go into a massive gym block for Charlie, and we get into a full-on prep to run, which we'll obviously go through everything in full. And if you have any questions, please drop them in the comments from this video or the next, and we'll see you next time.